doing. So the purpose of this particular meeting on a Sunday evening is to ensure that as patients, most of your queries might not have been answered at the treating center, or you might have something in your mind which you still require some clarifications about. And also, a lot of information on today's date is available on e-platforms and on internet, which might sway your opinions or your thought processes. So these are opportunities wherein we are going to have this as a quarterly event wherein you people can come up with your queries, which can be answered by who's who as far as the field of hemato-oncology is concerned. And as part of that, today, we are going to have this patient group meeting wherein we have the senior most hemato-oncologist and from the image group, one of the senior most members, Reena ma'am, who is currently a senior consultant in clinical hematology and is heading the Department of Medical Oncology at Tata Memorial, Tata Medical Center at Kolkata. We have Dr. Vaishali ma'am. She's a hematologist and currently is the director of AMYLOIDOSIS Center at Boston Medical Center in US. So we are very thankful to ma'am for being part of this discussion and the expert group. We have Dr. Sumit Meg, who is a hematologist, a bright young hematologist, dynamic person from Tata Memorial Hospital, ACTRAC, who is going to moderate the session today. And we have Dr. Gurleen, who is a senior consultant and lead hematopathologist at the National Reference Laboratory in Lal Path Labs at New Delhi. So she will take on various pathology or the diagnostic related questions. Now, the way we are going to have this meeting is Dr. Sumit is going to moderate it. So I would request all the patients or the people to kindly type out your queries in the chat box. And out of the questions which are typed out, the one which are going to be picked up and immediately answered would be the one which are generic in nature and which would help everyone. We would generally avoid few things. These are some housekeeping announcements. Number one, no names of doctors or the primary physician where you are getting treated with, because every physician has his own way of managing and every physician wants his patient to become all right. So there is no physician on earth who would want his patient not to do well. So no comments or no naming of the physicians. That's number one. Second, the amyloidosis is such a disease wherein, not like other infections or inflammations or other malignancies, you might see an immediate benefit because the pathophysiology is very different. So sometimes the recovery and the gains of the management would be seen only in long term. So we understand your anguish, but at the same time, no negative comments or the negativity, because the purpose of having these meetings is to ensure positivity and to help you support in your journey in amyloidosis. So let's avoid that. And third, no individual patient cases will be discussed, because both legally as well as otherwise also, without actually examining a patient or putting a hand on a patient, it would not be possible to give a judgment or a treatment for a patient. So we are here to generally answer generic queries and understanding of amyloidosis, how the treatments are, how the diagnostic availability, the diagnostic procedures which are available in the country are, and your queries about how to deal with the disease. So with that introduction, I would like to hand over the stage to the panelists and Dr. Sumit Meg to please kindly moderate the session. I once again thank the experts for sparing their time on a Sunday evening for helping out the patients. Over to Dr. Sumit, please.
Good evening, everyone. And I'm thankful that Team Image has given this opportunity wherein we can bring our patients on one platform and address their queries to a certain extent. As Dr. Uday sir already said, that amyloidosis is a rare and special group of disorders wherein diagnosis as well as response does take time. And even in the best of academic settings like in US, it does take a median of 6 months to get to diagnosis, even in amyloidosis. So I would request if anyone has queries, they can raise their hands or write it in the chat box and we can go to them one by one.
So Dr. Sumit, in the meantime, you can actually ask any queries or any points that you feel, because let me just introduce even that point to the audience. Dr. Sumit, along with the image, has really come up with a review article on all the research which has been done on amyloidosis from our country. So Sumit, in the meantime, till the time the patients would come up with any questions, you can actually shoot some questions to Reena ma'am and to Dr. Vaishali ma'am, who are here with us. Sumit, please take on.
Thank you, sir. So when I was collaborating or collecting the data of amyloid from India, one important limitation was, in fact, two important limitations were A, the median time to diagnosis again varies from anyways as low as 4 months to as high as 9 months. So I wanted to ask Vaishali ma'am as to what is the experience in US and how do you all go about it in your setting, ma'am?
Good evening, everyone, and thank you for having me. I'm actually visiting my 92-year-old mom in Ahmedabad. So this actually worked out. When the Colonel Uday asked me to join you, I said, I'm not sure, she's 92 and whether she's going to have a proper Wi-Fi connection or not. But, she was all set. I said, Mom, I have to do a meeting. She says, I'm going to make sure that the Wi-Fi is working, So there I am. And, thank you so much, namaste to everybody. And thank you so much for having me. This is obviously a passion of mine. I have worked in this disease for the last 30 years at Boston University and Boston Medical Center. And I think this is a very, very interesting question. And, I go back to a survey that was done by Amyloidosis Research Consortium, which is a patient-led organization in the United States. And this survey was a social media survey that was
Ma'am, we are not able to hear you. We are not able to hear you. Now,
Actually, I think you are muted.
you're muted, ma'am. Yes.
Are you able to hear me now?
Yes, ma'am.
Yes, I'm sorry, by mistake, I muted myself. But anyway, so the Amyloidosis Research Consortium is a patient-led organization, and that really conducted a survey on social media of about 400 plus patients and caregivers. And this was done in 2015. They published their results showing that 40% of patients required at least more than 2 physicians to really make the diagnosis. The diagnosis of amyloidosis was made by primary care physician only in 4% of the patients, meaning that the primary care physicians are supposed to be the gatekeepers for this multi-system disease, and none of these primary care physicians were able to put the pieces of puzzles together. And moreover, the median time to diagnosis from the onset of patient-reported symptoms was greater than 12 months in at least 40% of the patients. So again, that this was really, really showing this survey that this is a rare disease, and the awareness of this disease in the medical community is really, really lacking. We repeated this survey in 2022, again through Amyloidosis Research Consortium. It was a global survey. 1,200 plus patients and caregivers participated on this online survey. And what we found was, again, similar things, that the median number of physicians seen for AL amyloidosis diagnosis was at least 2, ranging from anywhere from 1 to 7. And the time to diagnosis, again, was greater than 12 months in 40% of the patients. Similar survey was also done in France, and similar results were found. So I think that it is crucial for a medical community to really think about this zebra as zebra without stripes, that when you have multiple symptoms that are not really fitting one particular disease, one must think of this rare disease because time is ticking. Patients' reported symptom to diagnosis, the delay really, really leads to worsening of survival, worsening of organ function, worsening of organ dysfunction. So I think that this is crucial. And, again, I think similarly, as you said, Dr. Mirk, that, it is no different in India. And it is no different in the US either, that this is a rare disease and you cannot really educate each and every physician in the community to really, really make this rare diagnosis.
Neena ma'am, your thoughts on this?
I was just kind of thinking while Vishalvi was speaking. I am not sure even in tertiary care centers, we pick this diagnosis easily. And most of these patients, because like Vaishali just mentioned, that they have so many symptoms which are related to different organs. These people may end up with the cardiologist, nephrologist, and even the bone specialists and so many other physicians, and they also take a very long time. So it's not only the community-based practitioners who, of course, have to deal with a lot of stuff. Even in the tertiary hospitals or multi-speciality hospitals, I think they keep going from one place to the other for a pretty long time. And 7 and 8 months would be quite okay. Many of our patients are actually beyond a year and a year and a half, and then they come with, the full-blown disease with everything, which then starts pointing towards amyloidosis. And by then, we know for sure that treatment delayed so long is going to take a long time to get the patient under control. And most of them will not even be able to cross a year without the treatment actually taking its toll. So yes, Image is doing a good job of educating patients, but I think it also needs to educate the primary care physicians as well as actually pick up the multi-speciality care people, and also, kind of bring them to the board where if you have a patient who's going to many different specialties, please think of this disease.
Agree, ma'am. Absolutely. So, Gurleen, you would like to add anything to this? You're on mute.
Yeah, I agree with Reena ma'am and Vishali ma'am. So basically, because of the non-specificity of the symptoms, patient presenting to different departments, leading to different protocols, and to the diagnosis and leading to the delayed diagnosis in such patient. And even after the patient is getting the has started the investigation, after that too, the biopsies, the patchy nature of the disease, the site to be chosen, and over and above that, the sensitivity of the biopsy leading to the diagnosis, and then the typing of the disease, when we later on can then decide about what course of action and the therapy needs to be done in the patient. So this whole process takes a long time in this particular entity, amyloidosis.
And ma'am, one more limitation was in when we did our analysis was while the gold standard is to do the diagnosis of amyloid with respect to its typing, whether it is light chain that is cancer related or not, is by mass spectrometry. Majority of centers, or in fact almost all the centers in India as of now, do the typing by IHC. As of now, I'm not sure if there's any established center in India which is doing the typing in India by mass spectrometry. So ma'am, Vaishali ma'am, what are your thoughts on this as to, is this IHC okay, or should we do something more beyond this? How do we go about it?
That's a great question. One of my tweets about this patient support group meets was that, I'm really grateful and, deeply honored to be part of this because, the resources are limited in India. Moreover, when I did with Professor Agarwal, the webinar few weeks ago on AL amyloidosis, everybody says that daratumumab is easily available. Yeah, sure, it is easily available. It's 2.5 lakhs of rupees per dose. It's a weekly dose. Who can afford it? My sister's mother-in-law has myeloma, and she's been treated with bortezomib for last 5 years, and they can't afford it. My sister, they are happy, they are well-to-do, but they cannot afford 2.5 lakhs of rupees per injection for daratumumab. So it is, I think the resources are very constrained, and I think that, and similarly, same thing in the United States. But having said that, I think that in India, what I have seen many, many times when I get patients referred to me are that majority of the patients even now have AA amyloidosis because they present with nephrotic syndrome. They have this untreated, they have very high inflammatory markers, and they have this untreated, undiagnosed tuberculosis that, we all have had, and we all have big, huge, PPDs and things like that. But, that they are untreated, and that eventually can lead to AA amyloidosis. Immunohistochemistry with, standard commercially available antibodies we know that it is inaccurate in 65% of patients with AL amyloidosis. And these are commercial antibodies that are available, in the market. Moreover, I think immunohistochemistry also requires a good pathologist and a good experienced pathologist to really make the diagnosis. Immunofluorescence on kidney. I'm presenting this case that I just prepared before I came here yesterday, that, I'm presenting at the International Society of Amyloidosis meeting, and it's called a challenging case. And that case was so challenging because the patient was already started on Dara-Cybordi. The renal biopsy showed AL amyloidosis based on immunofluorescence, which is a type of immunohistochemistry, which is based on antibodies that are commercially available. There was IgG, there was kappa, and whatnot. And he had no evidence of systemic plasma cell dyscrasia. So his serum immunofixation, urine immunofixation, serum-free light chains, and bone marrow biopsy were not suggesting that this was AL. We did do an abdominal fat pad aspiration. And what we do at Boston University is something called immunogold electron microscopy. It is a gold labeled antibody that is attached to the commercially available antibodies. So it's only for AA, ATTR, and for kappa and lambda antibodies. And we attach it with the gold label antibodies, and that specificity is 99%. And we found that the fat had TTR. So now we are all confused that, yes, he has this. So we sent the renal biopsy for mass spectrometry, and he had TTR in his kidneys as well. So the Dara-Cybordi was obviously not really treating the underlying pathophysiology, which was not AL amyloidosis or plasma cell dyscrasia. So I think gold standard is mass spectrometry. But I think and we don't send all the specimens for mass spectrometry. It is all because it is, again, expensive. Even in the United States, we don't do it at Boston University. We have to do it with Mayo Clinic laboratories. You have to have a contract between the hospitals and whatnot. But, this patient particularly did not have glomerular deposits. So in AL amyloidosis, most of the times the part of the kidney that is involved is the cup of the kidney or the filter of the kidney. But that is not what was involved by Congo Red. It was only the vessels, the blood vessels, and all types of blood vessels, the big arteries, small arteries, capillaries, arterioles, they were all involved with. So we knew that this was not really fitting the picture. And then we tried to untangle this challenging case. And I felt that, this was a good case to discuss with the group over there, just because, that yes, that sometimes you do need mass spectrometry to make the diagnosis. I think the other thing that I also feel when I get consults from India is that, this is again, patients are sending me emails all the time. And, there are a lot of patients here, they all are named Satish Chandra, but, I'm sure that behind Satish Chandra, there's somebody else. I hope there is somebody else, because that's the only, otherwise, it is Sumit and Gurlin and Reena, we are all just talking to each other, But, that when I get like emails from patients, I also feel that, patients don't have or they don't have the investigation of urine immunofixation. They just have the free light chains. They just have SPEP. So serum protein electrophoresis, urine protein electrophoresis are not the initial testing that are going to be positive in AL amyloidosis. So you need the immunofixation electrophoresis, and that is usually not performed. Even in United States, in community centers, small laboratories, they don't do immunofixation electrophoresis. They do UPEP, SPEP, and then reflexly, if that is positive, then only they will do immunofixation. So again, that I feel that is because, they are not screening tests, because the monoclonal protein is not really very, very high like myeloma. So I think that is one other thing that is important also. We do use mass spectrometry. I think it is challenging to set up mass spectrometry because you need a lot of, the library is very difficult to get. It's not the machine, it's not the expertise, but it's all the different types of proteins and the library, the amino acid sequencing, that is very, very difficult to maintain and get and whatnot, So, again, I think that some laboratories in India should have a contract with Mayo Clinic. I know that Dr. Wecklicker at National Amyloidosis Center also sometimes gets specimens from here, from India, to really do the appropriate typing. And, he has figured out a way that he can charge / bill, so.
Yes, ma'am. In fact, few years back, we had sent a patient specimen to Dr. Vichlekar for typing, and he rightly obliged by doing it in a quick period of time. Rina ma'am, your comments on the same.
Honestly, I have no experience with mass spectrometry. So it's, an occasional sample that has been sent out. Otherwise, more or less, we manage with the investigations that are more easily available to us. But something that I think is a good point for us in the profession to take home from Vaishali's discussion just now is that we need to do the urine and the serum IFE, despite the fact that the bands are negative. That is something we always, say bands negative, and so you don't go further. I take that point definitely back to my clinic tomorrow.
So Gurleen is from the lab perspective, from the lab side, and it will be very important to hear your perspective as to how do you go about for diagnosis of amyloidosis when you receive specimens in your laboratory.
So first of all, I again agree with whatever points which were made. The point that the full typing and the full diagnosis with the classification of the amyloid, but the reason being, especially in India, being the non-availability of mass spectrometry and electron microscopy, which are high sensitive and specific tests. In comparison, the IHC, as rightly pointed out, has multiple issues of masking, of light chain fragmentation, tissue contamination, unspecific and false positive and false negative test, false negative more than false positive. So challenge to diagnose the amyloidosis. And over and above, I think just not like if we are doing it bone marrow biopsy, the sensitivity is clearly very low. The combination of the biopsies gives much more likelihood of diagnosing the amyloidosis, like fat pad with bone marrow. So in such cases, we have higher chance, as we clearly know that the chances increases to 90%. We have combinations of surrogate sites biopsy, because the high chance of finding the highest chance of finding the is the vital organ biopsies, which is not very practical. So I think these are the practical issues which are being faced in literature. Also in Indian research work, also we know that most of the cases, most of the research work is showing till the diagnosing of the amyloid and the typing and all are only done by IHC. So the research work is also quite redundant and quite incomplete because of that reason in India.
Correct. And as Vaishali ma'am was alluding to in her talk, that she does find a lot of AA amyloidosis cases, and the same was in Indian data, that majority of amyloidosis was AA, and that too because of tuberculosis. Probably because TB is so common in this country, it has always been endemic and probably will be for many years to come. So I thought it was very India-centric problem, but I'm astonished to know that there are some cases like these in US also. So ma'am, how do you go about it if you have any AA amyloid patient? How do you counsel them? Because they don't have a blood cancer per se. So how do these patients respond, and how do you counsel them? Vaishali ma'am?
I can't, did you ask a question? Because I can't hear you.
Oh, I'm so sorry. I was asking that AA amyloidosis, secondary to tuberculosis, is also very common in India. So I was surprised to hear that you also see such cases even in the US. So what is your experience in such cases of AA amyloidosis secondary to tuberculosis?
Right. So, again, I'm sorry, I'm like, a little challenged over here, but so, our experience is obviously with AA amyloidosis is limited, just because, there's not too many infections, inflammation. We do see cases of AA amyloidosis related to juvenile rheumatoid arthritis. We do see cases of rheumatologic disorders that lead to AA amyloidosis. But again, with the new biologics and things like that, that is also, going down. We do have about 1/3 of cases in our series of, we presented this data at the International Society of Amyloidosis 2 years ago in Heidelberg of about 180 patients. 1/3 of the patients do not have an underlying infection or inflammation. They are idiopathic AA amyloidosis. And, there is some suggestion that obesity can set up this whole cycle of inflammation and can drive the inflammatory markers, serum amyloid A protein upregulation, causing AA amyloidosis. Obviously, the treatment is treat the underlying cause, and things do get better. So the nephrotic syndrome will improve if you control the infection or inflammation. We use a lot of colchicine as well, which is an anti-inflammatory / anti-TNF alpha, and that can reduce the inflammation specifically in cases of familial Mediterranean fever, which we don't really see a whole lot in India. We do see it in, I have actually a young kid from Pakistan who has FMF, and she actually lost her kidneys and she was on dialysis before she came to us, and that is how the diagnosis was made. So again, that it is common, but the treatment is treat the underlying cause. Inflammatory markers would be elevated, like SED rates, CRP. We have figured out how to do serum amyloid A protein through one lab, which is not affiliated with our hospital, but we do get serum amyloid A protein levels also to really follow their course of their disease. So, again, but I think that in India, I always have felt that AA amyloidosis is also quite common.
And ma'am, I had read that in myeloma, every sort of 20% patients do have concomitant amyloidosis. And so if you're not seeing amyloid in every 5th myeloma patient, which you see, probably you are underdiagnosing amyloidosis. We do have a lot of myeloma patients in our routine practice, but don't have that many of myeloma with amyloidosis. So if you could shed some
So,
light.
it is all about pathophysiology, right? So myeloma-associated amyloidosis is not secondary amyloidosis. It is myeloma-associated AL amyloidosis. And, again, that it is, you treat the underlying myeloma, underlying plasma cell discretion. And that is how the treatment is. 10 to 15% of patients with myeloma would eventually develop AL amyloidosis. Now, it's not just about the plasma cell numbers, because greater than 10% is myeloma, but you can see greater than 10% plasma cells in about 20% of patients with AL amyloidosis as well. So as far as you don't have hypercalcemia or renal failure related to myeloma, CAS nephropathy, or bone lesions, then, I would just call it AL amyloidosis with high plasma cell burden rather than myeloma-associated AL.
We have Atul ji, Satish ji, and Neeta ji with us. So if any of them would have their specific questions, you can please unmute yourself and ask.
Namaste. This is Neeta Sharma here. I'm one of the primary caregivers for my husband. And it was very rightly said, my husband's multiple myeloma was detected after practically 2 years. First, it was the amyloidosis of heart that came into the capture. And then subsequently, because there was amyloidosis in the heart, it was only indicated. I mean, so that's why the doctors were saying that when they had given the report, it was very good that they could detect it. So then we got the multiple myeloma tests done for kappa lambda, and that got detected. So we have been in the treatment for last practically more than a year. So I would say that the basic values are well under control, but there is one thing that I think it be valid for everyone else. Because when you are in the process of treatment, what happens is it's not just the values of, it's not just the multiple myeloma or the amyloidosis, but also the related organs that are being challenged. As small as, I mean, it's not a small thing, skin. the particular the system for, I would say the digestive system, everything gets challenged. So I would like to know what are the parallel other things that you doctors would suggest that these patients should take care of those organs. I mean, sometimes you would have, and the patients are not eating anything. Once you do not eat, there is a tremendous weight loss. Weight loss means muscle loss. Muscle loss means it's going to affect your bones sooner or later. So this is something that we can see now, coming. So now with your experience, with your vast, with different kinds of patients and all, some kind of protocols, if they can be given to the patients and the caregivers, so that we see that load, it's not there now, but it is coming. So, I mean, any further light on this, it will be very great.
Right. So Neetaji is asking about the supportive care treatment so that other organs do some kind of help with respect to along with the primary chemotherapy during the routine treatment. Vaishali ma'am,
Yes.
would you like to take this?
So, supportive care is absolutely crucial and fundamental to make patients feel better.
Voice,
But that
voice.
is not right. That's not going to take care of the chemotherapy, is not going to take care of the organs. Organs are already beat up from amyloid deposition, and we need to support the organs to really, really make the patients feel better. And, it has to be an integrated part of this coordinated care, because otherwise the patients are not going to feel better. Their quality of life is not going to improve. Unfortunately, there are no guidelines. International Society of Amyloidosis has created a working group that I'm part of, and we are developing supportive care guidelines. And I think patients with heart involvement, they need diuretics to really take care of the swelling, the shortness of breath. Patients with nephrotic syndrome, the kidney involvement, same thing, that they need a lot of water pills to get rid of the fluid. And I think nutrition, as you mentioned, Mrs. Sharma, is an important aspect of it. I think because of GI tract involvement, because of autonomic nervous system involvement, gastroparesis, meaning slowing of the GI tract, slowing of the gut, it is a huge problem. And I think that having small, frequent, low-fat meals, every 2 hours, there's something, we have a lot of nutritional supplements in the US, Ensure, Sustacal, Carnation Instant Breakfast, and that has a lot of calories. So even 1 or 2 cans of that, even sipping throughout the day. Some people like it over ice, some people like it room temperature, but whatever, kind of the patients prefer, those things are crucial, because that has a lot of protein. It also has a lot of calories. So that helps. And sometimes, we don't recommend it, but sometimes, we also in the United States use not appetite stimulants, because, we don't really want to use a lot of hormones, quote unquote, to really stimulate appetite, because there is some increased risk of clotting. But there is something called Marinol. Marinol is I don't really know what it is called here, but it's a cannabis. It is weed. I don't know whether things like that it is legalized in all the states in the United States, not all, but most of the states. And there are Marinol gummies available. There are Marinol oils available. There are Marinol cannabis ointments available. So, those 1 or 2 drops of that Marinol oil can also help patients feel better. Neuropathy is another thing, because the painful neuropathy is very difficult to control pain. And a lot of patients swear by cannabis oil that they apply on their feet. So, these are little tricks, but they do make lives of patients better. Constipation, diarrhea is another massive issue. And, again, if you have diarrhea, take Imodium. And, tincture of opium is one other thing that really, really helps patients as well with diarrhea. Constipation, obviously you have to stay ahead of the game, because if there is constipation because of autonomic neuropathy and slowing down of the gut, then, there is no appetite, because they've not moved their bowels for 2-3 days. So these are all, but again, these are very, very important part of the management of patients with AL amyloidosis that need to be looked at and taken care of. Low blood pressure. Patients keep, passing out if they sit up, or if they stand up, they keep passing out. And there are medications that would help to prevent this. High stockings, so that it increases the blood flow from the legs to the heart. Again, in 105 degrees here in Ahmedabad, I cannot even imagine anybody wearing high stockings, but we give abdominal binders so that that the blood flow from the lower part of the body goes to the heart and the brain, so that they don't pass out when they stand up or sit up. So these are some tricks that we have used. I'm sure others have used in the group also the similar tricks. But I think that Marinol is not an unreasonable choice for appetite stimulant. I don't know that is, do you know, Dr. Amerik or Dr. Nair, if it is available here? Everything is over the counter here.
No, ma'am, not as per my knowledge. Reena, ma'am, you would like to comment on that?
No, not yet legalized here. So you may get it outside a college, but you will not get it in the medical store.
All my patients, they take gummies to sleep at night or to really kind of feel better. They are little like not chewing gum, but the gummy bears, little things. And they all tell me that you need to start ordering these for everybody. So they really like it. Even the CBD oil, for peripheral neuropathy, it's generally,
So I think through image, we will have to make a recommendation and get it legalized first, and only after that can we recommend it. At the moment, it will be difficult to.
And as ma'am alluded
Yeah.
that such a multi-systemic disease that we cannot have a standard protocol for everyone. It probably needs to be individualized for each and every patient, depending upon what organs are involved, what severity of involvement is there, and depending on what patient can tolerate. So we have a few questions in the chat box. Shreya is asking that can we have Ayurvedic treatment for amyloid kidney simultaneous with allopathic medicine? All of us on this forum are allopathic doctors, and while I have a lot of respect for Ayurveda as a science, I cannot necessarily say that you should combine. Whatever one field of science in which you have trust, you should go with that and take complete treatment with that field only. At times, I do give Isabgol and certain basic Ayurvedic medications for constipation and other issues, but not otherwise. One more question from our side is, do we always need maintenance drug like lenalidomide after transplant? Her father had a brain stroke, probably because of lenalidomide, and right now he's in complete remission and not getting any maintenance therapy. I presume that she's talking about myeloma with amyloid and not only amyloid. Vaishali ma'am, would you like to take this question?
I know it's a tough question, because Shreya says it was only amyloid. So role for maintenance therapy, post-induction therapy or post-treatment in AL amyloidosis is not really studied. And we don't recommend it because the level of plasma cell burden is very low, unlike multiple myeloma. And most of the times, the remissions or the complete hematologic response is achieved with whatever the primary line of therapy is, are generally speaking durable. So we don't really recommend it. And I don't know what the cause of stroke was in your father, but if it was related to his heart, because the heart was badly damaged and there was issues with either atrial fibrillation or staggering of the blood in the heart, and that really caused the stroke, then I would probably also feel that it may not be reasonable unless he's on full anticoagulation to use lenalidomide. If it was a DVT or a deep venous thrombosis or clot in the leg, then maybe, after 6 months of anticoagulation, you can reassess the need for lenalidomide. But I think if it is AL amyloidosis alone, then I would not recommend, if he's in remission, I would not recommend any maintenance therapy.
Reena ma'am, any difference of opinion regarding that?
No, I kind of agree. The stroke, the other way is many of these patients, or almost all of them, are on low dose aspirin as well. And so whether it is hemorrhagic or thrombotic is something that I would take a note of. But maintenance in amyloidosis, we've just heard. I mean, the numbers in amyloidosis is so small that to really have a evidence-based answer for maintenance is going to be quite tough just now.
Right. She has commented that it was only AL amyloid and kidneys were mainly affected. So as Vaishali ma'am already alluded that the role of maintenance in only AL amyloidosis, especially the patient achieved CR, is probably not enough. And if the patient has had a vascular event, it would be difficult to ascertain the cause of what was the exact cause of brain stroke, whether it was lenalidomide alone or anything else. But the most important thing is that the role of maintenance, if the patient has achieved a complete remission per se, is not clear, and we would not recommend that. Atul Pandyaji, you wanted to ask any question? You are unmuted yourself. Atul Pandyaji, you
Unmute.
need to unmute yourself. We are not able to hear you. If you have difficulty in unmuting, you can just write it in the chat box.
Hello.
Yes,
Hello. Hello. Am I
yes,
audible?
yes.
Okay. I have done my ABMP in June, January 2020, and afterwards I am in a remission. And at least 1 year, my kappa lambda was under control. Then slowly, my lambda has increased. Initially from 30, 31, and today after you can say 5 years, it has reached to around 250. It is, you can say stagnant, but every time, every quarter review, it has increased around 4 to 5 numbers. So first thing, I'm a little bit paranoid up to what level it will increase. Second thing, I am at present in an pomegranate and very different maintenance doses. That, as Dr. Vaishali said, is not in possible for me. So I don't know what is the next medicine to control it. So if it will increase further, can I go for ABMP again? Or what will be the future I have to manage with this disease? I hope you understand me.
You were not very clear, but I would just like to summarize that as what I could understand. You did have AL amyloidosis in 2020. You were treated
ABMP. One more transplant I done in 2020.
2020, okay?
Yeah.
And you received treatment followed by an upfront autologous stem cell transplant followed by pomalidomide at present, right?
Yeah, that's true. And Dara I cannot afford it, and my lambda number is increased.
And your first line treatment before transplant was what?
This thyroid.
VCD. So
Yeah, BCD.
after VCD, autologous transplant and on pomalidomide, and there is some rise in the light chains.
I forget the name. Clarifin or what we call clarifin, the monthly maintenance dose.
Okay, so while it is very difficult to ascertain as to because it is without examination and without a clear-cut history, it is very difficult to ascertain. But Vaishali ma'am, if you have to put in a perspective as to a case of sort of biochemical relapse or some increase in light chains in a patient who is otherwise an amyloidosis, how do you go about if you have to think about retreating a patient of amyloid who is having only a biochemical relapse with some rise in light chains?
So I think there are two issues here. First of all, do you have, where did Mr. Pandya go? Yeah, he's there. Okay, Mr. Pandya, do you have lambda AL amyloidosis or do you have kappa AL amyloidosis?
Lambda AL.
Okay. And now the kappa light chains are going up or lambda light chains are going up?
Lambda light chain is going up. It was initially when I was diagnosed, its number is 6800 milligram per liter. And afterwards, I've done for ABNP. And after ABNP, it come down to 20. Again, it slowly increased. After 5 years, it again become stagnant at 250. While kappa is remained around 30-35.
So lambda has gone up to 28, you said, right?
250 number, yeah.
28 milligrams per liter.
250.
250.
250.
250?
Yeah, 250.
250 milligrams per liter. And what is happening to your organ biomarkers?
I can't understand.
Well, what is
Madam?
happening to your organ biomarkers? Meaning that did you have heart involvement? Did you have kidney involvement? What is happening to the
Okay,
protein
okay.
in the urine? What is happening to the heart? Yeah.
As such, my last diagnosis, there is nothing wrong with my heart, kidney, or lung. I have macrochromasia. My tongue has become swollen when I was diagnosed, and amyloidosis is generally mainly found in my gums and tongue only, not on kidney, not on heart, or not on any other major organ.
Mm. Now, may I ask you one other question? Did you
Yeah.
have improvement in your macroglossia, enlargement of the tongue, when you achieved a remission?
Yes, definitely. It's too much.
Okay.
It was a very big. Afterwards, it has come down, and at present, you can say hardly 10% is there.
Okay. Now, do you feel that the tongue is getting bigger again?
Very, I can say, psychologically sometimes, but very normal. Just 10% only, not like the when I was found at 2020.
Okay, okay. So, again, is tongue a vital organ? So, there are a
Yeah.
lot of issues that, do we really treat soft tissue disease, or do we consider treatment only for vital organs? Vital organs meaning heart, liver, kidneys. Those are the considered, quote unquote, the vital organs. I think macroglossia is the most devastating feature of AL amyloidosis because we cannot really control it. We cannot
Yeah.
remove the tongue. We cannot cut the tongue. And, it causes a lot of problems with breath, with speech, with eating. So the quality of life is terrible for patients with macroglossia. I think that in your case, if there is true free light chain elevation with considerable relapse of your disease, then the next treatment potentially could be VCD again, since you had VCD in 2020 and you did achieve a remission for 4 years. In the
Okay.
United States of America, we would do daratumumab as monotherapy, meaning with only daratumumab without combining with any other agent. But I think that, I personally know how impossible it is to really, really afford daratumumab in this country.
That's true.
I would say that maybe reconsider treatment with Cybor-D or bortezomib, cyclophosphamide, dexamethasone, just for 4 cycles, for 4 months. Because I
Okay.
don't want you to keep getting bortezomib and cyclophosphamide and everything if you do not have a response within 2 to 3 cycles.
Okay.
So, that is what because, you've had 4 years from it.
Yeah, that is true.
So
And
I think that
condition is
the
good.
measurement of the tongue in some way by yourself or by an MRI or something like that, there are no really true anti-amyloid busting agents to really take care of the tongue. I just had actually from my, my transit in Doha, I had a question from Illinois, Chicago, actually, from a physician about macroglossia. Because macroglossia, the patient is in remission, but the macroglossia remains a big issue. So what I suggested was, first thing is speech therapy, dental evaluation, making sure there are no dental caries, making sure there are no decays, making sure that they see a nutritionist, making sure that the diet is pureed, maybe a CPAP at night at home so that the tongue doesn't fall back and cause hypoxia or obstructive sleep apnea. So these are little things, but these are very important things that could help with the macroglossia.
Just add one thing. Because of the macroglossia, my dental has a big issue, and then I have to remove my front entire line, and I have to go for a micro dentures there. Because whenever I try, it has most of the size of my teeth has removed by the tongue.
Yeah, because the tongue, because oral cavity, the mouth cavity is a very, very small opening or a very, very small organ. And the tongue, when it gets bigger, there's no space for it to go. So the teeth get pushed out. So I think that obviously your dentist has done a good job. But
Yeah, yeah,
you may need to make sure that you are not developing gum disease, and so continuing following with the dentist, because that the tongue is a very, very, we don't generally recommend a surgery on the tongue to remove part of the tongue, because it's a very vascular organ. So, and with amyloid in the tongue, it is very hard for the tongue to heal. So we don't recommend surgical removal of half of the tongue, because it is going to grow back. So I think that the controlling the disease, underlying plasma cell disease, is the name of the game.
Doctor, one more thing. At present, my lambda is 250. Suppose it will increase further. At what level I have to go for again ABMP or SCT?
So, role of second transplant, it's a good question. So, I'm doing a talk for Professor Agarwal on role of stem cell transplant, and I will go over this, but I don't even know when I'm doing it. I think in September or October. But, I think second transplant, we are not generally performing in the United States, because we have other effective therapies. And if you received BMT and your remission was for 4 years with the first BMT, the second BMT remission is going to be shorter than 4 years. It's going to be 2 years, 3 years, less than that. And that is a well-known thing. And then there is always this increased risk of developing acute leukemia, because you are getting melphalan-based conditioning and whatnot, So I would, I would not suggest a second transplant. I would just try to put you back into remission with bortezomib, cyclophosphamide, dexamethasone, and do not do more than 4 cycles. If after 2 cycles, if your light chains are not decreasing, it is highly unlikely that they're going to decrease after 4 cycles. But if they're going down, then, and if you're tolerating it reasonably well, then continue with that.
Oh, thank you very much, Doctor. Thank you.
So the only thing that I can add is 2 years post a successful therapy, the dictum is that we can repeat it. And the second thing, as an encouragement, that we have generic DARA trials going on now, and hopefully by next year we should have drugs with daratumumab, which will not be so expensive. And once it comes into our generic brands, then of course, quite quickly we managed to get a lot of patients onto it.
So what company is making it? Because I'm going to talk to the CEO of the company.
Okay, I shall tell you that. Okay.
It is like they are late in the game. So many people in India need it.
Very late. So there is one which is a trial which has already started. It's a post-marketing. And there is another company. I don't know if I can tell it in an open forum, but I will definitely let you know.
I know.
It's a big brand in India. They are just kind of beginning to think, and they hope that in another year and a half, once 2-3 generics come up, then things become quite easy over here. Yeah. So in something which is slow going, and we know that he'll get a good 2 years remission, we will definitely bridge you till the data is available.
Right. That's very encouraging, ma'am, for Indian patients, and that's what always an unmet need, and hopefully we could tide over it in a short period of time. One question within the chat box is, Satish Chandraji has written that in his wife's case, the liver was the affected part because of amyloidosis, and there was damage to the anybody?
Yeah, erroneously it is showing Satish Chandra, but it is actually, sorry, Sumit ji, it is Dharamveer, it is my wife. In fact, I don't know, there's some mistake there. No problem.
Okay, no issues. Thank you, Dharamji. You would like to ask your question?
It is on my part. No problem. Yeah.
So yes. Yes, go ahead, Dharamveer ji.
Yeah. In wife's case,
we are not able to
October, 23 problem, and in December in ILB with amyloidosis, and then liver was the affected part. 2023, 30 January, the liver transplant was done, and it was done successfully in Max Saket. Thereafter, help of Dr. Vachlekar was taken from London. Dara was introduced. Things were going okay. But in between, she has been continuously having infections in different parts. Now, recently, the another problem being which has developed is the degeneration of bones. In fact, just in October last year, 5 vertebra where kyphoplasty was done because of the breakage or the cracks there in max only. Now, recently, yesterday again, she was admitted because of the acute pain in the back, and MRI detected another break in the vertebra. Now, tomorrow, she's again going to be operated to have another kyphoplasty. And the MRI report shows there is a serious degeneration is happening. The chemo medicines are, Dara, Cyclo, and Dexa, and also pomalidomide is being given as 21 days, then 1 week off, like this. So I don't know which medicine is badly affecting this. And she has more than 40 Dara cycles already. And now fortnightly cycles are happening with Cyclo, Dara, and Dexa. So I would like to have your advice. I mean, because how to check this damage to the bones? Otherwise, I can see the lady is going to have a very tough and bad time if she continues. Kindly guide me.
Right. So in a patient of amyloid who is otherwise on Dara, pomalidomide, cyclo, and Dexa on a quadruplet, as to how do we go about protecting the bones? Rina ma'am, your perspective on that?
Like Uday said, commenting on an individual patient may be difficult, but one is the basic bone density scanning, the MRI to see if there is what kind of involvement it is. And if it is very severely osteopenic, then I'm sure they would have started on bisphosphonates or medications that will help bone regeneration. So at the moment, I am unable to actually give an idea why this is happening. And according to the investigations, maybe some kind of bone protection agents would have to be used for this patient.
Doctor, do you think any particular medicine in the chemo which is harming, so that we need to check or reduce?
So with Cyborg D, the steroids is one thing that, and if we have been giving steroids for a long time, then we question. This patient has been on it for a rather long time, I think. And there is, in at least myeloma, there is quite a lot of effort now to do trials either without steroids or to stop steroids early. That is one drug definitely I would like to, especially if the disease is under control, maybe I will like to get that away from her treatment. And the second thing is, I'm not sure if she's on some kind of bisphosphonate injections monthly or 3 monthly or 6 monthly from the time this treatment was started, especially if she had very severe osteopenia to start with. And I would kind of think that you can discuss with your doctor if she's not taking, and then go ahead and under his guidance or under her guidance, plan for bisphosphonate injections. Of course, the general care before bisphosphonates is given will have to be done, including a good oral examination and a dental care before we start that. At the same time, if bisphosphonates for any reason are contraindicated, she has liver, not really kidneys involved. But if it
Correct.
is, then we have other drugs also available, and that can be discussed. Dr. Vaishali, your opinion on bone involvement in
No, I think I agree with you completely, Dr. Nair, that, maybe bisphosphonates, reducing dose of dexamethasone, not doing dexamethasone. I think I think there is also, we published something on bone amyloid that, we have also sometimes have had patients, not just because of osteoporosis and osteopenia, but also amyloid involvement of the bones. And again, that is difficult to treat. Kyphoplasty is the way to go to control the pain. And otherwise it's bisphosphonates, to strengthen the bones. So I think you covered it all.
Right.
Thank you.
Just 1 minute. There is a question in the chat box by Shreya that if kappa lambda both are elevated or both are high, is there a reason to worry? In her case, The lambda was 95, the kappa was 36 at baseline. After transplant, the lambda was 120 and the kappa was 76, which means the difference was more or less the same after transplant. And currently, both the light chains are 50 and 50 with a normal ratio without any M-band and no elevation. So per se, I feel that both are being elevated are not a reason to worry. It is merely the involved light chain, which we know at the baseline, either kappa or lambda for an individual patient. And it is the trajectory of that individual light chain which helps us to predict at times whether it is coming back or not. Vaishali ma'am, you would like to add anything on this?
Right, so this, free light chain assay and the free light chain levels are sometimes very tough to interpret in the setting of aging, in the setting of kidney dysfunction. And, again, in this particular case that Shreya is describing here, lambda 95, kappa 36. So the ratio to lambda to kappa ratio was a little bit on the, or kappa to lambda ratio was on the lower side. And now both of them are elevated. Again, I think you have to look at the whole picture. But, if both are elevated, normal ratio, no monoclonal protein, and if these were the things that were present before treatment at the time of diagnosis, then, this looks good. But I think this is as Sumit has been saying, that this is in context. We have to look at the whole picture here, and, just giving us the numbers doesn't really help us a whole lot. Can we
Okay.
stop Dictor on our own? Again, I think none of us here are going to recommend to stop, add, change any medications unless you consult with your own physicians. Because, we don't know what the Dictor is for and what the situation is and why stop Dictor and then feel short of breath or develop swelling and whatnot, So I think you have to talk to your physicians.
Right. One last question from the audience. Satish Chandraji has raised his hand. Can you unmute yourself and ask your question?
Thank you, Dr. Mig. I'm grateful to Dr. Uday, Dr. Vaisali, and Dr. Nair. In fact, I have been in touch with Dr. Vaisali and Dr. Uday for a long time. And in 2022, I was diagnosed of cardiac amyloidosis at AIMS, and they had done endomyocardial biopsy. But prior to that, as I was trying to relate my case with mediastinal lymphadenopathy, which was earlier for 5 months, they had kept me on anti-tuberculosis medicine. But after that, I was not getting any relief. So they, at AIMS, they started Andromeda protocol, and they completed it all from July 22 till May 23. And the lambda had come down from 478 to 52. But eventually, it was supposed to have relapsed probably, and it went up to 144. They changed DARA with BPD, and that also didn't work. It was always more than 100. So they were saying that it is, since it was cardiac, so anti-pro-BNP was consistently coming down. But there was a small semblance of this monoclonal protein, which was 0.22 or something like that. So the Dhara BPD, they continued till November. And after that also, when it didn't come down to less than 115 or 110, they said that they will start Melflan and Dexa, because I had never opted for various reasons for the BMT because of my age and also the cardiac condition. So recently in December again, they reviewed, and then they started Melflan with Dexa, but that also didn't work. And then they continued with Dexa and Melflan till February. Then again they changed. I was also seen by Dr. Vechlaker, and Dr. Vaisali was very kind. Aside from this image or sponsored her orientation today, she was kind to us and she had helped us, Amyloidosis Support Group of India. She has spent her time with us for pretty long time and gave us response to our several questions. So she knows our case and she is kind. Once in a while, she keeps asking my health and we are in touch. So anyway, but after February, again, the doctors, almost all the hematologists and Dr. Uday, I irritate him a lot, write a lot in ASGI forum to everybody. I will request you and Dr. Nair to get included in our group because we are frustrated, to tell you frankly, because this is a very dirty disease I had never expected in my life. So anyway, from March, they started my carfilzomib instead of Borti because Vachlekar Saab had said that that might work because that is the latest version, but that spoiled my heart because JLSS for my heart was 18 and it reduced to 10. So my treating doctor, as he declared last month that I am no fit for any other treatment in India and I must try with Dr. Vaisali or at Mayo and I must go. But for that, I need to get some approval from the government. So I'm waiting for that. But anyway, now I am on again back to bortezomib, cyclophosphamide, and Dexa, and that has started since yesterday. This has a very peculiar interconnection with my different organs, such as the spinal stenosis, because I had the spinal cord problem, and one Dr. Puneet Agarwal at Max, he is treating me. One pulmonologist, Dr. Vinay, Vinay Nangia is Vivek Nangia is treating me for the lymph node, and he saw certain scars in my lungs, so he had his own interpretation. Then the cardiac, there are regular echocardiography strain tests that are being done, which fluctuates certain GLSS or SPECT testing that is happening. Sometimes it is good, sometimes it is bad. But in kidney, it has not been a very detrimental situation in terms of 1.4 creatinine, then it will come down to 1.1. Overall, being a researcher, non-medical, of course, but I have been piloting and driving very hugely this amyloidosis support group of India, little bit whatever I could know. We have made a Facebook and Dr. Vaisali, Dr. Vachlekar, everybody is encouraging. Image is kind, they are patronizing us. So now I'm having two questions that they are saying that I am done with all possible combinatorial chemotherapeutic treatments, but this is affecting my cardiac uh, area. And yesterday, when I got my HRCT has not improved in terms of the size of the lymph node. Number three, the PET scan doesn't show any changes markable. So almost all the vitals I had done, and we have certain spectrometry machines in ILBS in Vasant Kunj. But I was just stuck. They had gone up to the level of protein analysis to certain level, then they don't have any software. I was trying to connect with Mayo or London, but we were resource constrained and we brought this to the notice of the government as well. But the worry is that for me, that whatever is happening in Mumbai with Dr. Agarwal, he had seen me long back. And with the different silos we are operating with the international consultants. So Dr. Mirga had heard you last time when you were talking of the blood. Two things I could note from your interpretation of Vachlekar's that paper, that heavy chain you were interpreting, and you were also saying that that mass spectrometry that has got certain connotation. So I'm worried if I had 1Q addition and 13Q deletion. So this disease in interpretation and interplay of several things. As I have heard recently, I have just now heard that secondary regions could be there, tuberculosis. So that is one thing. There is inflammation in my body. I was given the medicine. Number two, I had 478 lambda, which has affected my heart, which has come down to 100. Number 4, now my doctors, several doctors, hematologists. Dr. Uday is also my doctor. Rahul Bhargav is my doctor. Almost all hematologists in India, almost they know my case, even Pankaj Malhotra sir. So my question is 3. 1, that my lambda is not coming down. 2, my the spinal stenosis, it is creating problem for me, and which is keeping me confused why I am not able to move or walk as desired. Number 3, it is easy to plan to go to Boston or to Mayo, but I'm having the privilege and luxury of being a federal government servant, retired. So lots of data is coming through that. Otherwise, it becomes a very difficult situation for anyone without insurance to think of USA. My child is there. I am still not green card holder. So I am still exploring those options. But within the given situation, can I be pretty go on with the bortezomib, cyclophosphamide, and DEXA for 4 cycles, as told by Madam Vaisali. Number 2, should I have some hope, as Dr. Nair was telling, there could be something? And number 3, as a responsible person, as a facilitator for amyloidosis support group of India, what answers do I have other than just being a chemo brain fogged person and a senior citizen keep on bothering all of us? So these 4 questions I have. 1, my own survival and quality of life that is deteriorating despite 2 years of the best of the treatments that have been given to me in India, maybe because of my support from the government. And number 3, if I'm going outside, any miracle can happen or not. That's it.
So Satishji, that's a really long journey, it's an agony to hear your story. So to cut a long story short, you've gone through multiple treatments, and you basically wish to ask as to what treatment line should you go ahead for now, and what is the long-term outcome with that. So Vaishali ma'am, your thoughts on CAR-T bispecifics and how could he procure that with respect to his finances also?
So I think I know Mr. Chandra well, and I think the one question I had was that he's had multiple lines of therapy, and coming to Boston for a stem cell transplant when your heart is significantly involved and when your functional status has deteriorated could be potentially challenging, and we may not be able to offer you stem cell transplant because your heart is significantly damaged. Having said all that, you've had multiple lines of therapies, and you've had the best of treatments, as you've already mentioned. Do you know if you have translocation 1114? I guess you don't.
I
Because
have 1Q addition and 13Q deletion.
Right. So 13q deletion is okay. Like we don't really, it doesn't matter in AL amyloidosis. And 1Q gain. So 1Q gain really tells us that data may not work as well. If there's no translocation 1114, then venetoclax would be the other option but if you don't have that mutation, then it is not going to be really, really active. I think what I would generally, so you are not alone in this. There are 40% of patients who don't respond to what is available. So, unfortunately, you've fallen into those 40%. And, what I have done recently is that I've used teclistamab or some bispecific. I've also used elranatamab. There are clinical trials that are being developed in AL amyloidosis, but we've adopted these treatments by specific antibodies from myeloma. And how I have done it, Dr. Mirk and Dr. Nair, is that I just do the step-up dose, and I do the 1 month, the weekly dose of a month, and then I drop it to once every 15 days, and I just do it for 4 to 6 cycles. With the step-up dose, all their light chains become normal. So, we don't know whether to continue for 3 months, we don't know whether to continue for 6 months, we don't know whether to continue for 4 months, or whether to stop after just the 1 month. So there is a lot of unknowns here. Infections are definitely a big challenge. I think it is more so in myeloma than in AL amyloidosis. I have not yet experienced CRS or hypotension, so at least that part I'm like easier to do. But it is difficult to get it through insurance approval as well because there is not much data. So we've also done CAR T therapies for refractory relapsed long-term AL amyloidosis with a very kind of not very satisfying results yet. There is a new type of CAR T that is being developed, which was published by the Israeli group for 10 patients with AL amyloidosis. Now it is moving into clinical trials in the US. Very, very high response rates. Almost 100% of patients had hematologic responses, but 4 out of 10 patients died because of organ dysfunction. So again, these are all new therapies, but I do not suggest that these could be done outside of a clinical trial because we all want to advance science. We all want to make, these drugs available for the next generation of patients. So I think that, these should be done on clinical trials. They should be tested on clinical trials where there is strict monitoring and strict eligibility and exclusion criteria.
I have last question. Is there any new molecule which we could import if it is orphan drug which is approved by FDA in India that we can do? Or if I come at this stage to Boston, what advantage will I have in comparison to what is going on for me in India?
So I think the advantage of coming to a center like Boston University is that there is a comprehensive evaluation. We do comprehensive evaluation in 2 days for any patient, and you are sitting in one exam room. It's an outpatient evaluation. You are in one place, and all the doctors, different specialties come to see you. So it's a one-stop shopping that nephrologist, cardiologist, hematologist, pulmonologist, neurologist, GI specialist, they are all seeing you as a one patient within to Monday and Tuesday. By Tuesday afternoon, you are done. Your echo, your pulmonary function test, your functional assessment, your blood test, all that, whatever other imaging studies you need are all done between Monday and Tuesday. On Friday morning, we all sit as a consultant, as a meeting, all in a group, and we discuss all our patients, and we come up with a plan, and then a nurse practitioner or one of our members of the team conveys the recommendations to the patients and the referring physicians. So that is the advantage, because I think that you need a coordinated care. How bad is your heart? How bad is your kidneys? What is your functional assessment? Can you really, really do the stem cell transplant? Or your organs are too badly damaged to really not be a candidate for stem cell transplant? And things like that. And, I think we also make sure that you truly have AL amyloidosis, that we are not dealing with ATTR wild type amyloidosis in the heart. Because, you're describing some spinal stenosis, you are describing something else, and that makes me wonder if we are dealing with something little different. But, it is hard to really do all this over an email or over a support group, or over virtual meetings. I think that, what Colonel Uday said in the first place is that, we are all, after all, physicians. We've trained for a long, long, long time, and we all take great pride in physical exams and touching the patient. That is what tells us the best, whether how good you are or how bad you are. So I think that, Uday said it very nicely, right, Dr. Nair?
Yeah. Can I ask you one or two? Very often I find this happens for myeloma also and amyloidosis also. When things are stable and the FLC just starts about rising, is there a hurry to start treatment in these very indolent diseases, or can we wait till the patient is symptomatic?
So I think it's a great question. So, I go back to AL amyloidosis. Myeloma, sure, there's a lot of data on biochemical relapse and whatnot. I go back to AL amyloidosis. 25% of my patients who have had biochemical relapse with worsening of plasma cell dyscrasia have not required treatments at a median of 4 years.
Yeah, sometimes
again, so the rise in free light chains, is common and it can happen. But if their organ dysfunction biomarkers are not worsening, I would ride it out, because that may give them 2, 3, 4, 5 years. And then, you are going to have more treatments available, which are probably less toxic and more effective. I also have felt that, I think more and more is coming out on MRD resurgence, right? Like everybody's talking about MRD. And, we have data on that as well. So we have, 10% of patients who are MRD negative become MRD positive at whatever time. None of them at 4 or 5 years have required treatment, because then they don't have relapse of their free light chains. They don't have relapse of their other disease markers, So I think that we are in the learning phase as far as these things are concerned. I think, obviously if a patient has significant advanced heart involvement and now the free light chains are gradually going up, even if it's a slow relapse, I think you want to make sure that they don't get to a stage where the heart is not fixable. So I think it's very, very individual.
Your
But I think it's a
experience
great
on
question. I think biochemical relapses are real.
Yeah.
There's also something called free light chain drift with the nephelometric analysis of the binding site, that there is, that the reagents are getting quote unquote older, and the kappa light chains gradually are going up, the ratios are going up, and it is just related to the technicalities of the assay rather than true relapse of the disease.
the anti-fibrile antibodies and your thoughts on it, or your experience in clinical trials.
What is it?
There are some anti-fibrile antibodies which are now being tried for amyloidosis.
Is it a hype or hope? I don't know.
That's why I wanted to ask you.
I'm
how,
telling you,
know,
I wish it is a hope, and I
and,
truly, really feel that, then, Mr. Pandya will be the first patient to should receive it, because
Yeah,
macroglosia is so damn difficult to treat and improve, that if we have amyloid busting agents that can dissolve the insoluble pathologic extracellular fibrils, I think that would be it. Obviously, the KLM 101 clinical trials have been completed. We are waiting for the results. The problem is that it is an event-driven trial, and we don't have enough events because patients are living longer because they are getting treated with daracyborD. So they were supposed to, quote unquote, all die last year, but they're all alive. So they can't analyze the
That is good
trials
news.
because there are not enough events. So we don't know whether it's going to happen next year or the following year. I don't know. The
Okay, but in
FRAL
case
trial, which
we
is
are
a
hopeful.
Tamimab trial, which is ongoing, so we don't know how that's going to go.
And if Sumit is not going to stop, can I ask you another simple question? In only skin amyloidosis, how far will you go to actually look at all the organs?
So it's a good question. Skin amyloidosis is, different type of amyloidosis. It is not usually AL. It is usually lichen amyloidosis. It's from the keratinocytes. It never goes anywhere. And unfortunately, I have seen a lot of patients of Indian origin. They are all in the United States, but of Indian origin, and they have some scratching and they have this, and they go to a dermatologist, they biopsy it and comes back as amyloid. And these are all young patients in their 30s to 40s to 50s. And I do see them every 2 years just because, I don't really know that anybody else is going to look after them. But, it never spreads. It never goes into organs. So, every 2, 3 years, I would probably do some biomarkers and things like that. But, skin amyloid is never, they do have a lot of symptoms. Sometimes they have a lot of itching. And we do phototherapy with UVB to really control the itching. And that helps in it.
Thank you.
I am tempted to come to Ahmedabad for any camp clinic is going on there.
Oh, there's no clinic going on in Ahmedabad. Clinic is mom, who's 92 years old and still very sharp.
That's great.
So
My
lives
daughter,
alone. So my sister, who takes care of her, is traveling, so I decided to come and spend a week with her.
the progeny shows
She lives
the
alone, so she's a feisty woman.
yeah, one can make out. Thank you, doctor.
I know. Apples don't fall far from the tree. I know.
Right. And extremely apologetic for interfering here.
Ma'am,
We had 23 minutes. Yes,
I
good.
know. I need to go, I have to go to an uncle's place for dinner, and he's 88. So you can imagine 92 and 88. So they are going to be all, like ready.
Completely understand. We are 23 minutes overboard and it's Sunday evening and we would all like to wish some time with the family. I'm extremely grateful. In fact, it was a fantastic discussion with Dr. Vaishali Sanchurawala, madam. She has come to India and she's sparing Sunday evening for us for discussion. It's very grateful. I'm really thankful to Dr. Reena ma'am also and Dr. Gurleen Oberoi. And we hope to forward for having more discussions in the near future regarding amyloid. It's a complex disease and it requires a lot of discussion for us to overcome the fears which we have about the disease and also the myths which we have about this disease. So
My request is sorry for interference to Dr. Uday, is that today's conversation, if it is stepped, if it could be circulated in the group, we will be grateful.
So thank you, Dr. Sumit. Satish Chandraji, we really like that comment of yours. So what we are going to do is, because we understand many people could not have been participated, could not have got time to participate in this particular discussion, but the multiple points, take-home points, which Vaishali ma'am and Reena ma'am, and along with Gurleen and Sumit, which they have brought out, this will be available on Image website on the patient group heading. So this complete recording will be available there, free of cost for anybody who wants to visit it. And it will stay for a year's time, from 1 year from today. So it will be there on the website. So anybody who would want to go in and review these points or the comments by the various experts, they can review it there. So with
Thank
that,
you, sir.
yeah.
Thank you, sir.
With that, I would like to thank everyone for participating for this particular event on a Sunday evening. So we would like to meet again after 3 months. So any of the patients or the people who would like to jot down their points and keep recording it or send it to us, we'll record them for you and we'll answer those during the next meeting. Thank you. Have a good night.
Thank you.
Thank you,
very much.
everyone. Thank you.